One of the medical advances that has saved the most lives is the improvement of imaging tests.
The nocebo effect of imaging tests is a reality.
Seeing your body from the inside with millimetric precision reveals the great secrets of health and disease. But interpreting those images correctly, translating them into useful, practical and compassionate advice is not an easy task.
Damn, everything I've done all my life hasn't been worth anything, and now I have this aggressive cancer that's going to kill me.
How many backs have you seen that look really bad on imaging?
A back on the MRI that made me say, oh my God.
I got scared. Today's guest is a doctor specializing in radiology, author of Radiografía de una vida sana, and a science communicator with 500,000 followers on social media.
The MRI is a very powerful magnet that moves the atoms in our body.
His energy, warmth and good vibes are contagious. You'll see it right now. Welcome to Mejor que Ayer, Dr. José Manuel Felices. Dr. José Manuel Felices, how are you?
I'm very well glad to be here with you, Dr. Borja Bandera.
Welcome to our studio and welcome to Malaga. We have a fascinating episode ahead. I think you're the first radiologist, so you hold a place of privilege.
Well, people think my specialty belongs in the basement, but no, look, we're on podcasts too.
Absolutely, and that's how it should be. Let me ask you, can a report from a CT scan, an MRI, an ultrasound, any report make the patient feel more or less pain regarding their condition?
Well, yes, and I want us to do something. I'm talking to you, but I'm also talking to everyone who's listening to us, who's watching us. I want you to think about something, and that is, what did you feel the last time you saw one of your reports or when you were given some news about yourself? But especially when you read a report from an MRI, from an imaging test, you feel vulnerable, right? You think, hey, is this happening to me? What does this mean? And in the end, that affects you on a certain level. It has a neural mechanism, an established neurological mechanism that creates an aversion to movement, a fear of movement, a kinesiophobia. That nocebo effect, which is the opposite of the placebo, which would be good, that nocebo effect from the imaging test is a reality that is preventing many people from recovering. It's getting us into a vicious cycle of pain, and that's what we've come to fight against.
Kinesiophobia, fear of movement. I think that's something much more widespread than we think, because sometimes diagnoses or definitions aren't explained well, right? And so people are left with things like disc desiccation, bone edema, bone spurs, grade X patellar, chondromalacia, disc protrusion, right? And they hold on to that, or maybe not exactly hold on, but they use it basically to justify being sedentary. This actually harms them more in the long run, and I'm not blaming the patient.
But of course, it's everyone's responsibility. The point is that we have to be very clear, both as patients and as doctors and health professionals, that we need to support the patient. It's a joint effort. It's work that we do together, supporting each other. It's not just, here's your report and you're on your own. The report, what we see in the test, doesn't determine what the patient can or can't do or the patient's quality of life in the future, but rather how they feel. That's something I also want to ask all doctors to do when they share test results with their patients. When you order an imaging test, you're assessing the patient, but it doesn't show if they're better or worse. The patient tells you that during the consultation. How he feels, his symptoms, that's the most important thing. You don't have to wait for the test results to start doing something. If the patient is in pain and tells you, let's help him from the very first moment, of course. That's very important. And so when we have findings, what we need to see is, do any of these findings prevent my patient from doing some type of rehabilitation, or do they require urgent surgery? If the answer to both is no, let's manage it in the most natural way possible.
Of course, this is very interesting, and I think it's more relevant than people think. The typical clinical radiological dissociation they used to talk about in medicine, right? Which they explain to all of us, and sometimes I think that the professional, whoever is informing the patient, believes they know how the patient should feel based on the radiological finding, and that's not the case. Because how many backs have you seen that look really bad on imaging, but the patient is doing CrossFit and lifting a lot of weight and feels fine, or the other way around, right? Clean MRIs, but the patient is in bad shape.
Well, look, this happened to me recently with two patients who are also friends. One is a guy and the other is a girl. The girl, a classmate from college, had an MRI of her back that made me say, oh my God, I got scared. I was scared when I saw it. I said, oh my God, she arrived with mild lower back pain. She said to me, "Hey, Jose Manuel, I want to check this out. I'm not feeling quite right because it's limiting me. It doesn't let me do certain exercises," but she's perfectly fine. And you look at her back and say, "Oh my God, you'd be shocked by that back." And then I have another friend from school who can hardly move. He can't get out of bed and he has a hernia. That's it. So we have two extremes that on imaging, one really scares you and the other makes you think, well, it can't be that bad either. And yet their clinical pictures are reversed. What that should teach us is that not everything we see is something we have to grab onto. We need to relate it and, most importantly, listen to the patient, not just hold on to it.
Of course, and that's mainly about training professionals, which I think is crucial. Many physical therapists have come here, as well as some neurologists, to give a much different, more integrative perspective on pain and to talk precisely about this very common dissociation. The thing is, pain is something we still don't even understand 100%. So we can't take that for granted, obviously. In extreme cases, yes, right? If you have an open humerus fracture, that's going to hurt no matter what. But there are many things that are more in between that don't necessarily have to hurt a lot.
A lot of imaging tests only tell us so much, and luckily MRI gives us more and more information each time. But we should never think that technology will completely replace that physical examination, that clinical assessment. Ultimately, the clinical assessment is most important, especially how the patient feels. Because even with one or two exactly identical findings, the patient's perception can be different. And we also have to make that effort to try to listen and to try to put ourselves in their shoes, to empathize, right? Let empathy shine and let us shine as humans when it comes to tests too.
Yes, because radiology, maybe as we were saying before, a lot of people choose the specialty for the comfort of not seeing patients directly or being a bit more secluded, right? Yes. People who maybe don't have such a strong calling to be with patients every day? Yes. But in radiology, human contact is also super important. I mean, human interaction. I really liked the reel you posted recently that was about 30 seconds long, right? You, a radiologist, performing an ultrasound on a patient. In one, nothing at all was said. It just said, "We'll let you know." And in the other one, you were explaining like, look, this is what's happening to you. And in the end, of course, the anxiety generated by one situation and the other is completely different.
It's different, and the patient's perception is fundamental to their improvement. That is, making the patient feel supported will help you gain certain therapeutic tools that are well proven, like the placebo effect, which we mentioned earlier, and adherence to a treatment. If I manage to connect with my patient, I already have a percentage of the placebo effect because the patient will also want me to feel good because it's thanks to my well done work, and they will make more of an effort to recover. That's why on top of the placebo effect we've already gained, you also get better adherence to treatment. That patient will be much more willing to do what we've prescribed, what we've told them. So that's why there's that difference with radiologists, because we do communicate a lot. We talk with our colleagues every day. We're kind of the doctor's doctor because of the number of physicians who consult us when they're unsure about a diagnosis, and we can also communicate this to our patients.
A word from your book that caught my attention is engram. What is an engram and how does it relate to what we're discussing?
Well, engrams are the connections the brain makes when it performs a movement and finds it safe. At that moment, the brain establishes a connection like, okay, I can do this movement and I know how to do it. So a kind of roadmap gets laid down for how to do it and how far I can go. In the brain, a pathway opens up. That is very important when we have pain, when we have any injury. Gradually introducing those movement patterns that are restrictive because pain prevents us from doing them, introducing them little by little makes us feel safe and helps us overcome them. In a way, it's like, okay, I can do this now. That means I'm returning to as functional a life as possible despite my pain. When I gradually overcome things, that's part of my recovery. They may be small steps, but they're necessary steps.
It also really reminds me of the world of sports performance when you achieve a record. For example, I don't know, have you ever done CrossFit or anything like that?
Yes.
You lift 80 kilos in a clean or 90, whatever it is, yes. And then the next time you know your body can do it and you'll probably be able to do it a second time too, or in running any record, in the half marathon, whatever it is. It's the same, right? I understand it's similar.
Completely agree. It's very similar. In the end, it's the confidence you have in, well, I've lifted 100 kilos in a squat. Well, now I know that tomorrow I'll probably be able to do it again, but I've already done it. I no longer have that anticipatory tension, that fear, which in many cases is what blocks us the most. In movement, when it comes to rehabilitation, yes, it's the same. It's the same. I really like the parallel.
I just remembered. And Jose, what would you say to those people? Can I call you Jose? Yes, of course.
Of course. Yes, yes. Jose Manuel Felices. In fact, I have an anecdote about that. But while we were studying for the Meyer exam, I was always late to class and I would sit at the very back. And at the very back, there was another guy who wasn't one of the MIR students. And one day he said to me, "Hey, Alejandro." Of course, I didn't answer. "Alejandro, are you deaf?" I said, "I guess I'm Alejandro." From then on, that was my name. So he called me Alejandro. Then when we took the exam, he said, "Hey, I don't know how you did. I couldn't find you." And of course, if he was looking for me as Alejandro, there was no way to find me. I mean, whatever you want. Well,
Jose, which is the shortest, the most direct, right? What would you say then to those thousands of patients who live constrained by a diagnosis written on a piece of paper and is very specific? I don't know, for example, chondromalacia, and they say they can't exercise because of the chondromalacia.
okay, the first thing is that we have to bury absolute rest for practically anything that happens to us. I see. I just can't think of anything where absolute rest is beneficial. So, by burying absolute rest, I think those patients need to be aware that their rehabilitation and recovery will mainly depend on themselves. Well guided by a professional, whether it's a doctor or a physical therapist. The more interdisciplinary it is, the better. In other words, the more communication there is between us, the better, because the most coordinated and accurate decisions for the patient will be made. But the responsibility is theirs. The responsibility to do the things they need to do and to take steps to improve is theirs. Lying on the couch waiting for things to happen and letting time pass will make you better. It will make you better because of regression to the mean. Because what's normal is normal, your body will return as close to normal, as close to average as possible. But that regression to the mean, simply because of time and gravity, is not the
Much worse than if you do rehabilitation. Much worse, of course, because what you've already gained, that's what you lose. It brings other problems like sarcopenia.
atrophy of muscle mass. So it's extremely important for the patient to know that he is capable of improving and that he holds the keys to achieving that improvement. So if he needs to, he can call the locksmith. The locksmith is the doctor for support, but he has to turn the key himself. So it's very important that we do away with complete bed rest.
You've raised a point I'd also like to emphasize: interprofessional communication. I mean, I think that our system in general, not just doctors, but the whole healthcare system, has pretty poor communication from professional to professional. Among doctors, it's a bit better, okay? Doctors among ourselves usually talk. I go and ask the internist, I go and ask the cardiologist or whatever, or the usual consults. That works fairly well, but could be much better. But among professionals, for example, in rehabilitation, physical therapists, exercise professionals, nutrition professionals, and doctors, I think communication there is severely lacking. I don't know what your opinion is.
I completely agree. There's a huge lack of communication between us, and I think the main barrier to communication among healthcare professionals is ego. Of course, it's the ego, because as a radiologist, I receive many patients who come with ultrasounds performed by professionals who are not doctors. And, well, the professional who has the authority to make a diagnosis is the doctor. Any healthcare professional, I think it's fine for any healthcare professional to use ultrasound. It's a fantastic tool. Some call it the stethoscope of the 21st century, but I think that's unfair because ultrasound is much better. And also, the number of professionals who can use it is great, but it's very important that we act responsibly and with humility toward the patient in front of us. That humility should make us, when we might be missing something, be the ones to tell the patient, hey, it'd be better to have this person assess it, and that we make the effort to try to communicate with that person. Maybe write a report to pass on the information I've gathered as a physical therapist to the doctor, and vice versa. Because I think there's also a lot of ego from the doctor towards the physical therapist, out of reluctance to say, no, the PTs, ideally we should coordinate and communicate much better. Just like in your specialty, right, with nutrition, I think it would be much better for the patient. We don't have to think about ourselves. It's about setting aside our ego to give the patient what's best for them. And that, in addition, will end up feeding our ego because the patient will get better and will speak well of us. Like, hey, look, I managed to get better with this person because they worked in coordination with this other person.
Yes, I've started doing that. Now that I work privately with my team, after seeing a patient, I immediately discuss the case, limitations, and what I think might work best for them with the team's nutritionist and trainer. Then they tell me the patient has adapted better to this or that, and that's what lets us move towards something more personalized and better for the patient, as you said.
It's putting the patient at the center.
Of course, not egos, not positions, not who knows more or who knows less. Of course, that's not what it's about.
When a patient comes to us, the focus isn't that they've come to us, it's that you're coming because you're not well and you're trying to get me to give you a solution. You're not coming to me because I'm the best. No, you're coming because you're unwell and want a solution. You're at the center.
Of course, yes, absolutely. Sometimes we forget that. Yesterday, I was talking with a friend and he was complaining that, well, he had been treated badly at the hospital, right? Because he went and had been mistreated by a professional. I don't even remember what specialty it was. But, and he made an observation that is actually very simple, very silly, but I really liked it. He said, believe me, if I'm in this chair during Holy Week when I could be doing 1,000 other things, it's because I need to be here. I'm not here just for no reason. I don't really want to, so treat me well because I'm here out of necessity.
Yeah, it's true that the public system is really messed up. We're in a tough spot. The pressure on healthcare, the 6 minutes per patient in primary care. 6, my goodness.
In 6 minutes, I haven't even managed to say hello yet.
Of course. I mean, they work magic. I also want to say that there are a lot of family doctors. My wife is a family doctor and she comes home exhausted. Many times she tells me about patients she's worried about who affect her personally because she says, I just couldn't do more because, of course, they have to juggle with those 6 minutes. If a person only needs a prescription and it takes less time, staff can spend more time with others. Ultimately, we shouldn't have a system where you must juggle just to provide proper care for people.
It's also very twisted. It's not just the exhaustion of seeing 40 patients, but also the mental strain and the guilt and the sadness of not being able to see them the way you would like, right? Exactly.
Exactly. And that also makes many doctors take a more defensive attitude. And I understand it. I put myself in their place. You also have to empathize because people talk about empathy with the patient, but you also have to have empathy with the doctor and with the person on the other side. And that's what we're saying, right? That they have a schedule of 40 patients and probably keep thinking about the one they couldn't help the way they would have liked because they didn't have enough time or oh my, and suddenly something might come to mind. And it lingers with them, making them wish they could have done more for that patient. That also exists. And empathy with the doctor is very important too.
And you, Jose, what do you mainly focus on in your specialty? I know radiologists usually cover several areas, but you're quite specialized, right? Yes.
Yes, in the end we become super specialized because, well, the system also pushes us to do so, although we also like it, right? What I like most in diagnostics is the musculoskeletal part, although what I enjoy the most overall is interventional radiology, which is the other branch of my specialty. Because everyone thinks of diagnostics, which is the radiologist who looks at tests or does ultrasounds and tells you what's wrong. And then there's interventional radiology, which is using everything we know about imaging to operate. Without making an incision, which is the part I like the most and where I think we can help the most.
For example, do you have any recent interventional cases that stand out?
Well, yes, in interventional procedures, we can cover everything from pain management to curing tumors. We have that whole range, right? And it really surprises people. One of the most surprising recent cases is a patient who came in with, well, the daughter of a patient. The patient came in with a stroke. So, of course, when you hear stroke, what do you think? A heart attack in the brain. Of course, they arrived, the patient couldn't speak, couldn't move the entire right side of his body. He was practically pre-mortem, right? We could say, right, he couldn't speak, he couldn't move his body. So what function does this patient have left? Also, it was sudden. He was with his daughter. The daughter brought him with her husband and, well, they were terrified. Just imagine. We explained things to the daughter. The daughter, probably because of fear and shock, heard it but didn't process it. We went into the room and after 45 minutes when we came out, the daughter was extremely scared, of course. What did she think? That things hadn't gone well for her father. That it hadn't gone well, of course. She saw her father go into the operating room with half his body paralyzed, unable to speak, and after 45 minutes we came out. my father has died. That's the first thing she thought. And when she saw her father come out looking great, we told her everything went perfectly. She said, "What? How perfectly?" She kept looking at her father's head. Of course, what was she thinking? That we had opened his head and removed part of his brain to be able to... And then instead, when she said, "And where is it? What did you do to my father?" No, we went in through the groin. You gave him a groin injection and then removed it?
Explain if you want, like, of course.
It's because in this case, stroke treatment consists of going in with just a needle and reaching the area with catheters, with little tubes that we advance using imaging guidance. That's why we're radiologists. So we puncture in the groin, then we go up through an artery, we go up the main artery of the body, the aorta. At all times, we watch with the X-ray where the little wire is going. We guide ourselves. We have to keep turning the catheter. We guide ourselves to get in. So, for example, if it's on the left, no.
Into the left carotid, okay, so that's the artery in the neck, and now into the middle cerebral artery, okay, and now into the middle cerebral artery, the segment. We're getting more and more precise.
And at the moment when you're where the clot is, which caused the stroke, the catheter has a suction device at the tip, so it removes it.
It sucks it up, it takes it away.
It sucks up the clot. It's called a clot sucker.
And the blood starts flowing again.
Yes, the clot gets sucked up in a moment. And the blood, that road that had been cut off, that artery that had been blocked, well, a stone had fallen there, right? Bam! The stone blocks the road. Well, we've sucked up the stone and taken it away. How wonderful. You pull the catheter out, and take it out through the groin.
And only radiologists do that there. I mean, is the neurologist with you or not at that moment?
In Spain, there are some neurologists who do it, but generally we radiologists are the ones who do it. The interventional neuroradiology units, as they're called, are made up of radiologists. And in Murcia, for example, in the hospital where I trained and where I work today, in La Arexaca, there are 2 neurologists in the unit, but the other 7 are all radiologists.
That's great, really great. Changing the subject, it's true that in your book, you sometimes get into very personal topics, which is really good because it shows that doctors are only human with problems like everyone else, right? Yes. You mentioned that at one point in your life, you nearly developed orthorexia, becoming more obsessed with what and how you ate. Tell us a little bit about what happened here, and above all, to make it practical, what signs should people watch out for to know if this is happening or not in order to avoid this problem?
Well, I love social media. Ever since I was a kid, I've always been interested in health, and I've always been very up to date with all the information. And in fact, anyone who's watching you, I'm sure is someone who's concerned about their health. But what happened to me? I also used to watch you. Well, although this happened to me earlier because I was younger, but I read a lot and I started to get obsessed, right? I started without realizing it, but I started telling myself, okay, I have to eat this, I have to do things this way, I have to do this like this, I have to do this in this manner, I have to train this many days, sleep this many hours, and I started turning down a lot of plans. I think that's the main sign, right? It's one thing to turn down a plan, of course, but when it starts becoming a pattern, when it starts to be something that really separates you from the group of people you hang out with, I started to realize it when I saw that when I started my residency, when I started working at the hospital, and my colleagues would hang out together, they would go out after the hospital, have a drink, and I would say, no, I can't go. Because if I have a drink, and if I eat something heavy or whatever, then I won't be able to train, it won't sit well with me, and maybe I could go without ordering a beer. No, there's no need to drink alcohol, but could I join them? But instead of joining them, I preferred to go home and eat what I was supposed to, the way I was supposed to, so that I could get everything in order and then go to the gym, not feel heavy and be able to rest before training. Then I realized that my colleagues had bonds with each other and I didn't. And that's when I thought,
Yes, because you also seem like someone who's super sociable and who also needs friendships and connections like we all do, right? Of course.
No.
You don't seem like someone.
There I compared how I had been with my university classmates and how I was starting to feel with my residency colleagues. And I said, oh, there's a problem here because with my university classmates, I connected with everyone right away, made a lot of friends. My best friends come from that time. And then with the people from the residency, it was hard for me, and my first year as a resident was tough. It wasn't like I realized it one morning and it was solved. I would even say that besides, I had some bad luck there, because from my second year to my third year as a resident, probably when I realized all of this, it was during COVID. It was during the whole pandemic.
The pandemic, and also, well, yes, much more.
And then when I came back, that's probably when I got active again. And luckily, well, today I can say that I have very good friends from my residency program because, of course, I wasn't an unpleasant or unfriendly person either. It's just that I didn't take part in things. In fact, my peers were also happy that I started to join in with them. Yes.
Yes, well, maybe something similar happened to me. I don't know if it was so much with food, but definitely with work. In the end, any obsession is sometimes necessary to achieve certain results, but it also takes you away from health understood as balance, because in the end, health is balance in different areas. Getting out of balance in one or more areas moves you further from health. And it sucks, but a lot of people are in that situation. The good thing is, I think life gives us many opportunities to recalibrate, to balance. Yes. So it's good to have that reflection you had, like, hey, my friends are seeing each other 5 times a week and I haven't seen them in 3 months, to take action, right, in the end and get ourselves back on track.
Yes, I think it's very important to have that self-criticism too and realize that sometimes we might not be making the best decisions and that a good decision. Because, of course, everyone talks about diet, about eating well, about what you have to do, but nobody talks about this. Another part is, hey, diet and food are also social elements and a way to connect with others, especially in a culture like ours. So it's very important that we keep this in mind so we don't end up isolated because of thinking, no, I have to do everything perfectly. Because if I don't do it perfectly, then it's not worth it. That is to have a little flexibility, to ease up a bit, and also use food as a social element and as a way to connect with people. Because social connection is, in my opinion, just as important a pillar of well-being as nutrition, rest, and movement. Yes.
In the end, I think, really in the end, ask yourself what we are ultimately here in this world for, right? I always try to ask myself, but well, what's the point of living? Why are we here? And after asking myself 500 questions, in the end, I always come to the same thing, which is we live here to connect with others. I mean, to help each other and to be useful to one another. I mean, it doesn't make any sense. Like if you're on a deserted island, isolated, there's no one, you have no contact with anyone else. You would eat just as well. In the end, everything we do is ultimately so we can keep enjoying the people around us, ourselves, and shared experiences, right? And so for me, that's the basic foundation. The thing is, studies don't really measure it because it's very hard to study. How is that? All of that is subjective. In the end, it's about feeling lonely, right? Purpose, optimism, lack of optimism, these are very soft metrics that can't really be measured. But for me, nothing makes sense if that's not present. I mean, you can have a sleep score of 100, but if the next day you have no one to share it with or
no one to enjoy being well rested with?
Of course. Everything in the end is connected to being useful to others. Your work in the end gives you that feeling that there's someone next to you whom you're helping. Without that person beside you, you wouldn't want to be a radiologist. For what?
Exactly. I think exactly the same. In fact, in one of the chapters of the book that talks about friendship, right? And that's the medicine that Epicurus prescribed for us, right? He talked about friendship as a lifelong painkiller. When at some point in the future we face hardship or suffering because illness and death are inherently part of life, having a friend to share it with is the best painkiller we can have, right? Obviously, we will be there and so will the doctors to give you all the life support you need. But it's true, having a hand to hold. Whether it's a friend, a cousin, a nephew, a son, a brother, or a partner, whoever it is, the person you share those moments with will make those moments much better, much more peaceful. So I see social connection as just as important, and that's why even though diet, movement, and sleep are fundamental,
life, the other thing is that we have to do the work as a society. That moments of social connection don't always have to be associated with other negative elements for health. Food, drink, just staying up late, and maybe drugs or whatever. There are plenty more. That's what they are. Because there are many ways, and I think that, I don't know how old you are right now, but I think that younger generations come with more of a mindset of social connection without harming your health. For example, running classes with parties afterward, right? They mix in a bit of that party vibe because you're 20 years old and you want to go out and party, but you don't necessarily have to drink 3 cocktails, right?
Yeah, that's true. Now, the thing is, I was born in 93, so I think we're about the same, right? 90s, we're in the same boat, yeah. But I think we've seen and we see those who are 10 years younger than us, who are already 22 or 23. I mean, they're already in college.
Well, many have already finished college, and you think, well, they've put alcohol aside. The statistics show that they stop drinking so much alcohol and start drinking more energy drinks.
Well,
The truth is we don't know, but clearly none of them.
of the two is ideal. If I have to choose, I think the change isn't all that bad because alcohol is definitely a proven carcinogen.
It's likely less harmful than alcohol, but like tobacco and vaping, it's still a lesser evil. They keep vaping and can't stop.
Switching one poison for another. But what I also completely agree with is that we don't need to go overboard to have those social connections or go out, and just because I'm going to eat with my friends doesn't mean I'm going to get totally wasted.
That's the fear that the biohacker has, or the issue that the person who's obsessed with this has. That's the fear. But like you said, there are alternatives you can look for. Going out and having a drink, well, it could be in the afternoon, right? That classic afternoon hangout. You get home by 11 and sleep, and the next day you feel perfectly fine.
You don't have to get drunk, and you don't even have to drink alcohol. If you need to drink alcohol to have a good time, the problem isn't the alcohol, it's the plan. It means you don't like the plan. Look for other things you enjoy more. If you find something where, hey, you don't need to drink alcohol for it and you still have a good time, maybe you don't like going out partying, and it's just that everyone else goes out partying and you feel like you have to do it because that's what you're supposed to do, right?
You like hiking, you like going out to play paddle doubles.
Then you go and do climbing and do that, hiking, or it turns out you like sailing, I don't know. So maybe the problem is, if what you need to have a good time is to drink alcohol, the problem is the plan. Change the plan, you don't like it.
Yes, totally. You also had a setback that you talk about in the book, right? Which was your spinal injury. Tell us what happened to you and how you managed to get through it.
At the start of my residency, many things came together for me. It was when I started, after finishing the MIR, following a long period of being sedentary, because remember that studying for the MIR means basically 9 months sitting in a chair 14 hours a day with everything that comes with it.
You hurt me.
I would finish studying at 11 or at 10:30 and I would go to the gym, and from 11 to 12 when the gym closed, thank goodness for McFit back then, which closed at 12, and I would train at that hour, which was honestly terrible.
It's really bad. I would come back at 2 in the morning.
I would come back at 2 in the morning and, well, in the end I would have dinner, and by then my schedule was completely messed up, but well, it was what worked for me in some way. But of course, after that time of barely moving, I finished the Spanish medical residency exam and I hadn't stopped training. So of course, I went back to living my life exactly the same as before. And after all that time, my back started to tell me, actually, by the end of my studies, it was already telling me something. It already hurt. And look, it was associated with a period of prolonged inactivity. A few days after being in the hospital, one of the doctors I was rotating with said, kid, something's going on with your back. Let's get an MRI.
Because she could see I was in pain. Of course.
I was already moving around since I couldn't sit long. I noticed the pain was radiating. She saw I was restless and asked, but what do you feel? Even though I didn't say anything, she could tell I was uncomfortable. And of course, as a doctor with 30 years of experience, she noticed. She said, what do you feel and what do you notice? I told her and she said, you need an MRI because something's wrong. And then we'll see what it is. And really, there was my hernia, right? That moment was a real shock because I didn't really know. At that moment, what expectations did I have? And I said, oh my God, I'm 25 years old with a herniated disc that was compressing the foramen, compressing the nerve. And I said, what do I do about this?
What is this? You already thought you were going to need surgery, and man,
the doctor I consulted told me that surgery was scheduled for the following week. And I got scared. The truth is, I got scared and said, wow, I really didn't expect this at all. Of course, I started studying, reading. I became obsessed. For about a week, I probably read everything that had been published. But starting from the 1950s, everything that had been published, I went to the Regional Library of Murcia to look it up in the archives. I even went to the university's general archive. I became absolutely obsessed. But anyway, in the end, I got a rough idea. Above all, I found a study that talked about the epidemiology of a herniated disc that resorbs on its own. And well, they gave some metrics and an average, and they talked about a man under 30 years old, previously an athlete. And I said, damn, is that me? That's me? and an 80-something% rate of herniated disc resorption. Man, damn, that's me. I can't just let this go. I also looked into what the warning signs are for a herniated disc. Because of course, I'm not saying there are a lot of people who take this to mean that hernias shouldn't be operated on, and that's not the case. Herniated discs require surgery only when necessary. The main criteria are loss of strength, meaning that we can't move something or that a part of the body suddenly stops responding. For example, we stand on tiptoes and our foot drops. Careful. Loss of sphincter control, meaning that we pee or poop ourselves. Saddle anesthesia, meaning we don't feel anything between the genitals and the anus. Erectile dysfunction is sometimes included, and persistent pain despite proper treatment for 6 months. Of course, I didn't have any of those. So if we don't have any of those, I think it's worth it. Of course, after being evaluated by a doctor, it's worth taking an interdisciplinary approach with a physical therapist and a trainer as well to get back on track. And that's what I did. When I saw that I didn't have any warning signs, I consulted with another doctor. In this case, I asked him, "What do you think I should do here?" And he told me, "You don't have any warning signs, don't get surgery, let's try it and we'll monitor you for these 6 months, let's see how you do." And I started getting better. I kept improving. I surrounded myself with a great team. Actually, I had 2 teams. I got so obsessed that I even had 2 physical therapists because I thought, damn, if 2 doctors gave me different opinions, the same thing could happen with 2 physical therapists. Of course. So I had 2 physical therapists and I also had a personal trainer who was with me through all of this. He helped me. They all helped me a lot. And to this day, I care about them a lot. I send my regards to all of them.
Did it get reabsorbed?
It got reabsorbed.
Have you checked it on imaging?
Absolutely. I had it, well, the onset was in July 2018 and I had pain until coming back from Bali. The last time it hurt was in November or December of 2019. That was the last time I had continuous pain. Since then, the pain intensity decreased a lot, but I still had a nagging feeling. Well, coming back from Bali is the last time I remember that. Then I had a small relapse a little before the pandemic in March 2020, and since then, that's it. I didn't get any more imaging tests because I was fine. Why would I want to get an imaging test if I'm fine? That's another thing. There's no need to do an imaging test if we're clinically fine. So I repeated the imaging test sometime later in December 2022 because my left side started hurting and I thought, just in case. Well, I got into the machine. When I came out and saw the images myself, seeing that the hernia wasn't there, I had pain on the left side, but the pain on the left went away. I forgot that my left side was hurting and I was so happy. Of course, I called my father, my mother, the physical therapist, the coach. Just imagine a few years later, but the joy of seeing that it wasn't there and especially of that team that worked with me. And that's also a part that I've experienced as a patient and want to make the most of as a doctor. Because look, what's my first reaction? Well, to call my parents and my wife and to call the people who have been with me to achieve this because I wanted them to be happy too. I wanted to share that with them. So as a doctor, that's a strategy I try to use every time I have a patient in front of me. I want the patient to also want me to be happy because they have gotten better. Of course, that will help them get better if that's the case. Some people might say, oh, but that's selfish, right? Some colleagues have told me that. I say, I don't care if it's selfish or not, if it helps my patient get better.
To get better. And what role does trust play in recovery?
It's fundamental. It's fundamental. As we were saying earlier, we achieve the placebo effect, we achieve adherence to treatment, and we achieve that. If I trust what the person I'm working with is telling me, if I'm with a physical therapist I trust and he tells me, let's do this. Why? Because look, because I've seen this, because I've studied this, because this is what you need. Because I have another pool of patients where it has worked, and I keep doing things, and I see that it has truly helped me. And I see that I am truly improving. Each time I will not only trust more in what he is telling me, and therefore I will be able to incorporate new movement patterns, but I will also reinforce my desire to see you again and my motivation to follow everything you are telling me to the letter. So I think that's fundamental.
And trust, which directly clashes with the attitude that makes people feel fragile, right? Some professionals warn, be careful, you have a serious injury. Don't do this or that because something could happen. In the end, it's like the overprotective father or the overprotective mother, right? Who is always instilling fear and destroying confidence. There's no other way to put it.
That's the concept of absolute rest. Absolute rest is something I understand. I understand that precaution. I understand that when there wasn't enough research, I get that in the 80s, well, in the 70s and 80s, not enough patients had been studied. How did they respond to physical therapy, to movement-based rehabilitation, right? And with progressive loading, I'm not saying on the first day, but for example, eliminating deadlifts or eliminating exercises is very similar to eliminating foods. There are no bad foods, there aren't bad foods or foods we have to eliminate. It's all about context. The same thing happens with exercise. And the main thing would be to think that not moving is much worse than moving incorrectly. Moving incorrectly will activate certain motor patterns. It might not be ideal for us. That's why it's also essential to do it with the help of a health and movement professional. But no, not moving will always be much worse.
Of course, yes. Well, Marcos Vasquez always says it, right? Yes, in the end, above all else, the most harmful thing is not moving. Yes, yes. There's a quote you've included in your book from The Art of War that I love, which is the victor first wins and then fights, and the defeated first fights and then seeks to win, right? Exactly. That's from The Art of War, yes. And you use it to explain prehabilitation. What is prehabilitation?
Well, prehabilitation is, well, this is a concept that came into my life in a very tough way, but I think it's very necessary for all patients. Prehabilitation is being in physical shape, being in good physical condition so that when we get sick, because prevention is fundamental, it's very important, but prevention is about reducing the likelihood of getting sick. We're never going to bring it down to zero. Never. No matter how perfectly we do things, but prehabilitation does give us some guarantees. Prehabilitation is about increasing the chances of recovering once we've gotten sick. And that is indeed a guarantee because if I am prepared beforehand, at the moment when illness inevitably comes into my life, thanks to prehabilitation, my recovery time and my quality of life until I recover will be much better. It will take me less time. And also I'm going to have a less difficult time. Therefore, I want to be prepared in advance. Do I want to prevent illness? Yes, but above all, I want to be prepared in advance. And besides, these are things that go hand in hand because prevention and prehabilitation don't mean I have to do some things for prevention and other things for prehabilitation. In fact, they go hand in hand. That's why I also think it's a way to reinforce everything we've been saying on social media, right? And that we try to convey to people that movement, sleep, and nutrition, because prevention and prehabilitation really do go hand in hand.
Yes, in my specialty, especially before bariatric surgeries, prehabilitation is very important. But well, also before any surgery, I think being the classic being strong for surgery, right? Because it's a huge stress on the body. Yes. And in general, it's a concept that can be applied to all of life, right? I mean, if you're training today while you're healthy, you're prehabilitating yourself in case one day, God forbid, you get cancer or something else, a serious pneumonia that puts you in the ICU, or a COVID-27, not COVID-27. Yes, yes.
Exactly.
Whatever, right? In the end, life always has its risks. The risk is never zero. And the more prepared you are in times of peace, right? For the battles that might come your way, the better.
I completely agree. If there's ever a COVID-27, just know they're going to say all sorts of things about it.
Yeah, just like The Simpsons, right? Bodia already said it on the podcast, didn't he?
But yes, I completely agree here. In fact, for me, what I think about training and all these things we do, muscle mass isn't just to look good. Of course, it's also so that, as you said, if at some point when you're 70 or 80 years old you fall, you don't fracture or break anything. If when you're 65 or 70 years old, God forbid, but if it happens to us, we get cancer, well, we'll be able to recover better. And I say that the concept of prehabilitation really hit home. It came into my life because I've experienced it, not as a patient, fortunately, but as a family member of a patient. My uncle had esophageal cancer with not much chance. Esophageal cancer is very aggressive. And, well, he had esophageal cancer. And when they told him he had taken care of himself, he was someone who loved going to the doctor. My cousin used to say he preferred going to the doctor over playing golf. And it was probably true because he liked knowing he was healthy. He took care of himself, especially with his diet. He loved pomegranate. And he used to say, I'm getting my antioxidants, right? I mean, he was a person who, even though he was a lawyer, had medical training and he liked it and he worked out every day. So when he got that diagnosis, of course, the first thought you might have is, damn, everything I've done my whole life has all been for nothing. And now I have this shitty aggressive cancer that's going to kill me. Well, what a load of crap. This has all been for nothing. Instead of that, and this was a lesson he gave to all of us, really to everyone, even to the oncologists who saw him, his attitude was, well, I'm more prepared than other people to face that surgery you're talking about. An extremely complex surgery, 14 hours long, with a thoracic phase, an abdominal phase, I mean, one of the most complex surgeries. And the guy said, hey, I'm ready for this. He began training days earlier, aware of his cancer, wearing a bracelet showing he burned over 5,000 calories daily. That's how active he is. That's just how it is. And every day he was training, getting ready, saying, I'm going to go into that surgery in the best shape possible. And he really went through the surgery and it went by without any complications. He finished and kept doing the ball exercises in rehab, also in an obsessive way. He finished and kept going. He walked, he trained, and that's what allowed him to do it. He still passed away, but the quality of life, he probably extended his life a little bit, but much more importantly, the quality of life. From the day he was diagnosed with cancer until the day he passed away, it was excellent. My father says that my uncle passed away and he doesn't know it, and I completely agree. My uncle passed away, in fact, on the day we're recording this, a year ago.
Exactly a year ago.
And he doesn't know that he's dead. He doesn't know it. In fact, when he was admitted and I went to see him on a Thursday, he told me, well, they're keeping me here for the weekend just to monitor me, so I'll spend the weekend here, and on Monday they'll discharge me. He passed away on Sunday. He didn't know he was really sick because thanks to all that effort, to that prehabilitation, and to how good the diagnosis was and how well he kept himself, he died peacefully, perfectly.
Yes, the course of an illness is radically different. If you're well, if you've done things right, it's not like that.
So I think the lesson is very clear. Taking care of ourselves, maybe not to increase our lifespan, but to improve our quality of life and to die without suffering.
Yes, switching gears to athletes, for example, since you're very interested in everything related to the musculoskeletal system, what role does ultrasound play for an athlete? For example, now they talk about assessing muscle glycogen or muscle glycogen replenishment, the hydration level of the muscle, or the percentage of fat nutritional changes. So, is it really useful?
It is useful if handled well. It's true that in this case, we might still need a bit more research and time to perfect the data we collect, how we do it, and to standardize it so that everyone does it the same way and it's as accurate as possible. But it's true that ultrasound being so accessible and having no risk for the patient, non-zero, because a lot of people say, well, it's true that on certain tissues like the eye, but well, we're talking about grown-ups, right? On healthy adults. And we're also going to do it on the muscles. Ultrasound has zero risks. That's the message we need to get across. Entonces, so using it for these kinds of things, which maybe aren't so standardized, but since there's no risk, it's useful, it's very useful. Measuring muscle glycogen, measuring diameters, measuring hydration. It's one of those things that when you also like ultrasound and you get together with people who like to train, with Neko Bas and Carlos Alex, we did a small study. You see the three of us training at Esparta, the gym where we go, to see if it gets more of a pump or if the diameter increases more after sets of 10 repetitions or 5 repetitions, and they were doing biceps curls, right? Then I measured their biceps diameter to check for differences. And we got an interesting video out of it, and the truth is there really aren't any big differences. There aren't, as long as you get close to failure. In other words, there weren't big differences. We did find differences if, for example, you did the set of 10 with an RIR with 3 or 4 reps in reserve, and the set of 5 you did almost to failure, right? We don't recommend anyone do bicep curls for 5 reps to failure. But, well, it's true that you could clearly see that difference in how, the pump,
the diameter, an ultrasound machine at the gym. Yes.
An ultrasound machine, a butterfly device as they're called, which are portable. The portable ones, of course, now you can connect them to your phone. Of course. So,
you can do an ultrasound here. Yes.
Anywhere. In fact, they're the size of a cell phone. It's like carrying 2 phones.
How much does a device like that cost? Well, it depends on where you look, but you can spend as much as you want. You can get a decent one for 3,000 or 4,000 euros. Well, it's not, not much more.
It's not too much.
Good. That's great. That's great.
That's great. Acceptable?
Something acceptable, a quality. Yes. And Jose, you mentioned a lot of mistakes, right, that people frequently make and that can cause injuries or problems and so on. One of the ones that worked best was this one, right? Yes, people use this more.
Yes, people use that incorrectly.
I can't travel without this, I'm telling you. Tell us why.
You're going to start using it better. Look, this also happened during the last farewell trip for the radiology residents when one of those who was leaving was like this on the plane. He had this facing forward, of course, that's logical, right? Of course, he was like this on the plane. He was like this the whole time. And just like that. And I told him, but Pedro, you're going to break one of these times you'll break your neck. And Pedro was like, no. He said, but that's useless. I said, but don't you realize it has to be like this? He told me, but how is it going to be like that? With the other one, look, this way your head doesn't drop. It supports your head. I mean, when you're about to get whiplash, it holds your head. And he told me, but that's not possible. And he told me, let's ask ChatGPT, of course, like the gold standard, right? And ChatGPT said I was right. And I said, damn, this is a video. This is clearly going to go viral. And that's how it was.
That's how it was, right? I mean, what we want to avoid is getting whiplash, of course.
In this case, the anatomical factor is that behind you, you have the backrest, and it's pretty unlikely that you're going to get whiplash backward, right? In fact, since it has these, it also covers a gap here. So between the backrest and this, it holds you pretty well from behind. But going forward, you need the support.
And this stopper, no, it's not there.
You don't have it here. Your head slips. Also, you make a bit of a wedge, right? And you move the device itself. You open it with your chin. So you put it like this.
Yes. Well, from now on, they're always going to use it like this.
Changing lives.
Yes, one detail. Also, the typical posture of constantly looking at your phone, which I think we spend hours like that every day, with your head at a 60-degree angle, looking down, shoulders forward. What can that cause when it's repeated?
Well, you can see that in the X-ray. You can see it in the MRI. You can see cervical straightening. It's like I have straightening of the cervical spine. So does that mean I shouldn't move anymore? It's actually the opposite, right? When we have that position, what we're actually doing is shifting the weight of our skull forward and taking it out of our center of gravity, taking it out of the place where our muscles are prepared to support it properly. So, by taking it out of place, our muscles aren't prepared, and the effort they have to make is much greater. That's why we get those strains and those muscle knots people talk about, right? Those painful spots. Those painful spots are because you've made them work too much, you've tightened too much the cables that hold your skull.
The occipital bones and all that, right? All the muscles.
Yes, all the deep muscles of the neck. There are a lot of muscles, but also the big ones, right? The ones everyone knows, the trapezius, the rhomboid, all the main muscles.
So what we should try to do is, of course, strengthen them so they can better support that load. The stronger they are, the better they'll support that load. And of course, give them a break. It's being like this 8 hours a day. If we sleep 8 hours, work 8 hours, and the rest, the other 8, we're like this.
We're close to that.
Yeah, that's a bad deal, right? A bad deal, and it's normal for those neck pains to persist. So doing strength training to improve the whole area, all the muscles of the trapezius, rhomboids, lats, and also doing some mobility work as well, right? And broaden your perspective a bit and look up. Actually, the best mobility work we can do today is to go outside for a walk and look around and not walk with your phone in your hand. That's the best mobility work. What can we do today? Because nobody does it. Go outside and look around.
You miss a lot. You just look at the ground while walking through a city.
Of course, look at the trees, see the birds, see the dogs, see the sea. If you live in Malaga or if you live in Barcelona, well, Barcelona also has the sea. If you live in Madrid, then you see the towers and watch people moving around. And that dam is also something really beautiful, isn't it? And I think we're missing out on a lot of things by trying to look for them on the phone. Life happens right here in front of us.
So people understand what are the fundamental differences between a CT scan and an MRI?
Okay. To be very practical, without getting into physics or anything, just being practical and focusing on what matters to the patient. CT uses radiation, MRI does not use radiation, so that's a point for MRI. Next, for the patient, CT is very fast and MRI is a bit slow. Point for the CT. CT can evaluate the lungs, MRI can't evaluate the lungs, it's due to the physics. Point for the CT. MRI not only shows morphology and anatomy, but also functionality. It shows what's happening at the cellular and molecular level. Point for MRI. So, is one better than the other? There isn't one that's better than the other. There's an indication for each patient. It's true that MRI is starting to replace CT scans, and it's becoming superior to CT, offering better resolution and giving us much more information in many conditions. But CT is our best friend in emergencies because it's fast and it lets patients go in with medical devices. If you need life support, if you're intubated, you can't go into an MRI, but you can go into a CT scan. So the CT scan always for now, is going to be around for a long time, and it gives us a lot of excellent information. Above all, excellent. For the lungs, CT will continue to be the main test. And for everything else, I do think that MRI provides more. It provides more and more every day because every day we have more technology. Why?
Is it because it's slow? I mean, why does it really take so long?
Because of the physics of how it works, and also to make it very simple. The CT scan is a picture. The CT scan uses X-rays like the one where you stand there.
Thousands of pictures, right?
That gets reconstructed. It takes pictures. And of course, in the end, those pictures are taken very quickly. A CT scan takes 20 to 30 seconds. But the MRI, in order to create the image, what it does is it's a magnet. The MRI is a very powerful magnet, like the ones we put on the fridge at home, but super powerful, that moves the atoms in our body and then they return to their place. So what does the MRI do? It sends magnetic pulses to move the atoms in the body. And it measures the time it takes for them to align, the time it takes for them to return, the time it takes to get back to 50%. And it can measure the hydrogen atoms according to the sequence, according to what we're asking it to do. And that generates an image. Of course, it has to measure times. You have to wait. It does it several times. That is, it needs a very large amount of data to be able to provide that information. But my father, who is also a radiologist, says something, which is that when he arrived and he was a resident in the 80s, the CT scan took half an hour. Of course. And now it takes 30 seconds. When I arrived, the MRI took half an hour. Probably in 40 years, it'll take 30 seconds. When I'm my father's age, I'll tell you, Borja, that MRIs take 30 seconds, of course. I hope so.
I hope so. Yes. It would make things much easier. And regarding diagnosis of, plaques, the coronary arteries and so on, we have the famous KIC, right? Which is the coronary calcium study, right? Yes. Okay. Correct me if I'm wrong, but it seems outdated. Yes, because it only detects hard calcified plaque. Now we also have new ways to measure soft plaque, right? Exactly.
That's right. Well, here we have, the KIC rats, right? Which is the score we would give a patient by taking that CT scan. And we would say, okay, these arteries have this much calcium, right? They have, more than just calcium. They have this much plaque, right? Of atheroma, which in the end is what's blocking the passage, what's blocking the road, the artery. That tells us what has happened. I mean, it's giving us a snapshot of the life the patient has had previously, but it doesn't predict what might happen to them. So it's clear that if we see a blocked road, which is what we see with a normal CT scan, and the blood can't pass, the cars can't pass, and they have to pile up. Well, hey, at some point that road might end up completely blocked and the cars can't get through, the blood stops flowing, heart attack. Okay. But what's the probability of that? What helps us with that? Let's see. The CT angiogram, which is also combined with artificial intelligence. The CT angiogram combined with artificial intelligence is a type of CT scan. With it, we can see not only how blocked the road is, but also if any of those stones that are making the road narrower have a chance of coming loose. It has a chance of coming loose and not just blocking that road, but that stone could roll down the road and block a smaller road. That could also give you a heart attack. So what this combined technology allows us to do is to assess the patient's status and predict what could happen to him, which is very interesting for individualizing the treatment as much as possible.
That's great. Also, have you seen the lungs in radiographic images of a frequent vapor? What happens here? Yes. Are there changes? Yes.
Also, you can see, it's not just that you see changes, but you see changes that hadn't been seen before. That is to say...
You mean not even with tobacco?
Not even with tobacco. You see different changes.
How? Why is that?
Tobacco causes what is associated with tobacco. Well, it's more emphysema, COPD, right? Chronic bronchitis, where the bronchi fill up with mucus. Emphysema is when the lung gets destroyed, and instead of parenchyma, instead of tissue, it just fills up with air completely because it becomes useless. So that's what we used to see more typically associated with tobacco, and also some very small nodules called smoking-related respiratory bronchiolitis. These are small lesions like little bumps, as if the lung is getting little pimples. Just like we get pimples on our skin when something irritates it, the same thing happens to the lung. It also gets little bumps. Well, these little bumps from vaping have a very typical shape, and we know they're from vaping because it's very characteristic. And as radiologists, we're able to see that. We see how it leaves a band of sparing right on or just below, right on the edge of the lung. That is, it affects the central area in a very characteristic way, which also draws attention. You see that the entire periphery remains unaffected, and you say, wow, what's this? Those are changes that, as I said, hadn't been seen before and can be directly attributed to vaping. So, is one better than the other? For now, we don't know. We haven't been at it for that long either. But the changes it's causing, honestly, I don't like them. We're just swapping one poison for another poison.
They're both bad, you know?
They're both bad. Is one better than the other? Probably. There's some British study, right, that said it could work as a bridge therapy.
But I think it's not being used as a bridge therapy. It's not being used in people who didn't smoke and now vape, right? I mean, just because, I don't know, because everyone does it, or because of social pressure, or because they're fun, or because of the colors, the marketing, the flavors. No, it doesn't taste like tobacco, which tastes bad. It tastes like melon, like watermelon, right?
Exactly. That's the big win the tobacco industry has pulled off on us. The tobacco industry had already done enough damage with tobacco. Nobody argues about tobacco. And now we have a group of people who are able to argue about the use of vapes with all kinds of fallacies of different sorts, right? But in the end, what the tobacco industry has managed to do is give you a colorful product that shines with a watermelon scent that doesn't smell when you finish smoking it. You get home after smoking and your mother says, yo, you've been smoking. You get home after using a vape and your mother doesn't notice.
She doesn't notice, whether it's with nicotine or without nicotine, right?
Of course, with nicotine or without nicotine. No, mom, this is good. This doesn't have nicotine. It's just that it has other things too, like propylene glycol, well, a bunch of other substances that aren't good for the lungs. And the nicotine in the end is the hook. It's what gets you hooked and keeps you smoking, because that's what it does at the level of the receptors. But it has other things that also cause changes. Here they'd say it's not combustion, but it still causes certain changes. There's no combustion. No combustion in your body, man. The defenders of vaping say it's not really combustion, but that's because you're not burning anything, right? But it's still a battery that heats up a liquid. I mean, it also has its own kind of combustion, call it whatever you want, right? So it is definitely causing some very clear changes in the lungs, which can be directly attributed to it. And that's the big trick the tobacco company has pulled on us, so that we forget about and leave tobacco alone. And we say, well, if this is much better, we add colors, we add flavors, we add things. And they're selling us the same thing under a completely false premise. And they're taking our money, exchanging it on top of that for our health.
Yes, and it has spread. I didn't expect it to be so widely accepted. I mean, in just 3 or 4 years, you go anywhere and I don't know, kids who are 15 or 16 years old are smoking there.
Yes, that's the issue. Teenagers who never would have considered smoking. They vape because it's cool and it has colors and it has... So that's definitely not what we're aiming for, of course, as a therapy. As a bridge, well, I don't know anymore. But the criticism has to be direct and very clear, because there are a lot of kids who would have never smoked and who are vaping, of course, and they're destroying their lungs.
There's a question I've always wanted to ask a radiologist, so I'm going to ask you, and it's about longevity clinics, which, well, are also booming. Well, one of the tools they use is ultra-early diagnosis, trying to diagnose everything as soon as possible, right? And now there's a boom happening, not as much in Spain, but more in other European countries, and especially the United States, of preventive whole-body MRIs for longevity purposes, right? Yes, obviously, as a doctor, I know this will have... Yes, you can find useful things. For example, the other day I was talking to a colleague who owns one of these clinics, and he said, no, we've found aneurysms that we've clipped, and probably, or maybe not, they've saved the patient's life, right? Yes. But then also I was arguing with him about what happens with incidental findings, what happens with the iatrogenic harm caused by inappropriate treatment of those incidentalomas, if that's the case, right? What do you think about this? What are the pros and cons?
Well, it's very clear, both the pros and the cons. On one hand, I want to invite you to reflect that there's a lot of marketing behind this. And obviously, the fact that it became trendy in the United States is no coincidence. And that the trend started in the United States is no coincidence. Because that's it, a very strong intention to make money behind it. At the end of the day, what we're suggesting is that you become our client. It's about attracting you as a client for life, right? Because we've created that need for you and you're going to keep doing it and you're going to get a full body MRI that you wouldn't need. Yes.
Something is going to show up.
Of course. Well, something is going to show up. I mean, it's an expensive procedure. And also, hey, you're going to spend some time in the machine, but we've already hooked you for life. We've created a need for you. And for the rest of your life, you'll come here, clink, clink, cash register. So on one hand, I want to share that little reflection for people who, of course, have heard about it and feel like they need it. You have to consider that this need might be more manufactured and more unfounded than it actually is from a health perspective. On the other hand, in this system, in the Spanish healthcare system, which has many advantages, that's possible.
No, I mean, this is only possible in the private sector. I'm asking specifically about that. If MRIs become very cheap in the future, costing around 100 euros and available to everyone, that's a different matter. But I'll ask about that later. Okay. But let's go to the scenario of, a private patient who has the money, who has the cash, doesn't mind paying whatever it takes. Do you see that as more favorable or not? Or the other way around? I'm not sure if I'm explaining myself because it has its usefulness. For example, in body composition, all the guidelines always say it's the gold standard. Yes. An MRI measures visceral fat, sarcopenia, muscle, all of that really well. Yes.
I completely agree that it can guide you. It can give you guidelines for changes in your life. Because the MRI, for example, the DEXA or bioimpedance, right? Or the DEXA, which has been mentioned as the gold standard for body composition and so on. Of course, the DEXA tells you composition percentages and tells you, well, you have this percentage of water, this percentage of muscle, this percentage of fat. Okay, but how are they distributed? Where is each part, right? This happened when Ibai had it done before the physical transformation that caused such a big change. The DEXA,
You say?
yes, he had a DEXA scan, which, by the way, the DEXA uses radiation. I told him, I said, be careful with this because your audience has a lot of teenagers and you're encouraging them to get a test that uses radiation. Of course.
But regarding bioimpedance, for example,
Of course, he did it in a completely, let's say, positive way. And in fact, I think the message he conveys is awesome, right? I wish more influencers made positive physical changes like him instead of promoting Burger King. But the thing here is that the MRI also lets you know where that fat is. No, not all of it is the fat we see under the abdomen. The fat that surrounds the organs also causes inflammation and is toxic to the organs. And especially the muscle, the fat that infiltrates the muscle. A muscle made entirely of muscle fiber is not the same as a muscle that starts to have fat infiltration. That muscle doesn't have the same functionality as a top-notch muscle, right? So in that case, it can help us say, hey, this patient should focus on this type of training. It's not going to be as decisive as it seems because in the end, what you have to do is train, eat well, rest. I mean, I don't think it's going to change the rules of the game as much as it might seem from a marketing perspective. Yes. But it's interesting. And above all, sorry, for the brain, they're also able to estimate a brain age. Of course, with the changes in MRI and also together with artificial intelligence, they can predict and estimate what your brain's age is. And I think that's actually even more interesting than physical body composition because it really can help us. For neurologists, it can help guide the patient towards certain interventions. Like, hey, maybe you should have a little more social contact, or maybe it would be good for you to do some math work, or maybe it would be good for you to do some identification or structure work. Who knows? And it can help slow down brain aging. Thank you.
yes, the question might be more interesting that way. If we were a society with unlimited resources, where a 5 Tesla MRI costs, I don't know, 30 cents, and we could give everyone in the population an MRI at age 20 and again at 50, would you do it or not? Because obviously we're going to see a lot of aneurysms that will clip. Maybe we'll find stage 1 tumors that we wouldn't have seen otherwise and we'll treat them. But we're also going to see other things that will need to be defined very clearly, whether to treat them or leave them alone, like thyroid nodules, incidental adrenal adenomas. So would you do it or not? Because I have mixed feelings about that too.
I like it better when it's put that way. I prefer the idea of doing it at 20, at 50. It no longer creates that need to do it constantly, but instead we have a baseline. For me, having a baseline is very interesting. What is a baseline? So that everyone understands, right? It's knowing how you are today.
Like knowing what your body was like at 20 exactly.
And that way we can also see what has happened. Hopefully we won't need to do any for you between 20 and 50 since everything has gone well and there's no reason to think anything is needed. But it can show us what's happening in your body, right? And what changes there are. And above all, if something happens, we have something to compare it to. In other words, we're not going in blind. What we're seeing here has more value because we can compare it to something. Yes, that's true. I would find it very interesting, although I share that doubt with you, you know? Whether this is optimal, because we would see a lot of incidental findings. It's not the same to see an aneurysm as it is to see a lung nodule in a smoker. That's something where we can have a certain degree of intervention. A renal tumor, which is the most typical one that is found incidentally, but we can also see hepatic hemangiomas that don't have any cysts. Simple renal cyst, megacisterna magna in the brain, and causing anxiety for the patient. Of course, if you tell a patient, look, you have a megacisterna magna in your brain, oh my God, right? Take it out, right? And it's simply a little bit of fluid accumulation, just a bit more fluid in the posterior part.
Yes, that's where communication comes in, the communication strategy and reassuring the patient, right? Of course, it's normal.
I think it can cause a lot of anxiety in certain patients. Even with that, even if you explain it to them, because we all have in mind the patient who, even when things are explained, it still stays with them. The constant worry, you know, it's human, it's completely human. Holding on to your concern, it's your health and it's your megacisterna magna in your brain, right? In some way, it can worry you. It's a normal anatomical variant like many others. So yes, it's interesting, but it would have to be done with a lot of strategy and in a way that's very close to the patient. And above all, knowing if I find something, what's the next step, of course. Having that framework in place, right? I wouldn't get the test done just to see what's there and then figure it out if something shows up.
Yes, in fact, that's my counterpoint. I mean, I see the pros very clearly and I think this can also save lives. Yes. But the cons would be, okay, I see the thyroid nodule, I get an ultrasound, and from there I'm going to have to keep monitoring my thyroid nodule with ultrasounds for 25 years. Yes, I found something incidental and now need a functional study to check hormone production, which means a year of medical tests. And we've turned someone who was feeling fine and who actually wasn't a patient but a healthy person who was feeling fine. He probably is living a very active life and doing great into a patient who has to undergo tests for X years. Yes. Maybe those tests won't even improve his health, but they will definitely worsen his quality of life. My main counterpoint to all this is that it's already here, and I think it's here to stay.
Yes, I feel the same way. And with thyroid nodules, we share that experience. I have one here.
Big one?
No, I hadn't noticed, but now that you mention it, yes.
Yes, almost 5 centimeters. I might get radiofrequency treatment, and we'll ask you about it later.
I already do them, so no kidding. Welcome. Wow. Welcome.
I'm going with Mersha.
Yes, whenever you want, of course. Well, for example, the thyroid nodule, we have that TI-RAD system, right? That way, so people understand, it's the points we give to a nodule to determine the probability of it being benign or malignant. So when we see something and we have that structure, the next thing we would do is this or that. And for the vast majority of them, we do some follow-ups. Sometimes I think about the number of micropapillary carcinomas, right? And they're there and they're not going to know. They're not going to cause this person any problems in their life and they'll die of something else with their micropapillary carcinoma, never even knowing they had it, and it won't cause them any problems. But on the other hand, if we do something, if we biopsy it now, they have a micropapillary carcinoma, we take out part or even all of the thyroid and we're condemning them to take Euthyrox for the rest of their life. Well, I don't know. That's where I think we need a lot more reflection, a lot more research on this. Currently, we're not as prepared as I'd like since I wish we could provide answers, but to be ready and offer answers, we need to actually take action. So that's kind of the back and forth.
And then there's the economic issue, which will create a need for many tests that either the patient will have to pay for themselves or it will further overload the public system. It's
a topic that's already there.
It's already overwhelmed. Now, these factors must be considered, but that's where everything is headed, including early cancer diagnosis. Now in blood, tumor DNA and RNA can be measured, yes. And ultra-early diagnoses of many types of cancer can be made. So in the end, everything is heading in that direction.
I think a very positive era is coming, and artificial intelligence is also going to help us a lot with all of this. In my specialty, it's going to free up our time, right? And it's going to allow us to do many more things than we do now. And it's going to free us from tedious tasks, helping us make them more human or do different things that maybe we didn't do before. In other words, it's going to open up other opportunities for us.
Yes, I think about it and I say, until very recently, I used to write out the lab results like hemoglobin 9.7, hematocrit 50%, and so on, etc. And a few weeks ago, I said, why? Why do I spend 7 minutes or however long writing this when AI can write it perfectly well for me and I could dedicate those 7 minutes to the patient, of course. And I think those things even doctors sometimes don't realize, and that's the kind of thing we need to take advantage of AI for.
Of course, I already use it every day. I have AI, our work systems, right? With 3 screens, yes, and I have AI running constantly. So I write my report, I do it exactly the same way I would have done it 5 years ago, right? When this didn't exist and no one mentioned artificial intelligence. I write my report, finish my report based on what I'm seeing on the screen, then I give it to the AI and tell it, look for possible mistakes I might have made. Look for distractors that might be present in this type of pathology. Suggest differential diagnoses that I might not have considered. Add recommendations to my report for the colleague who reads this. Add recommendations for the patient in my report. And all of that in seconds, it takes a report that was already good and makes it excellent. Because it makes me reflect, hey, could I have missed this? Maybe I didn't notice because it's not a condition I see every day. And the AI tells you, well, look, people usually see this. There are times when it got confused because it was this, okay? So then I do a second reading of that study in a very focused way, guided by what the AI has pointed out to me. And in the end, that's excellence for the patient. So without talking about crazy things or robots or anything like that, something pragmatic that's already here. And I think if the radiologist isn't using it, they're not taking full advantage of the benefits it can offer.
And it's true that AI is more accurate in diagnosing certain pathologies than radiologists are today.
It's true that it's a tool we really need to keep in mind. We need to keep it in mind and we need to embrace it. Because its ability to analyze an absurd number of images, far more than a human could. How many images does AI see in seconds? Images that I might need a whole lifetime to see. So, and what kind of learning does it have, right? Especially if it's coordinated. So I really think it would be very interesting. And it's very interesting for us to incorporate it when evaluating images, probably together. And thanks to what AI does, it's also tedious for us radiologists to be searching for lung nodules and spending 10 minutes looking up and down a lung to see if there's any little nodule that could be cancer. Well, hey, if AI does it and it helps guide me better, I'll still do it, but it gives me more guidance after its analysis and go in a bit more confidently. And above all, it allows me to spend that time on other things, to look for other things. And when I find something and have to interpret it, to give it a bit more time, to communicate it better, or to call my colleague, the doctor who requested this, right? And hey, this is what it looks like to me. What do you all think? If that's what I'm thinking, does that make sense to you? Does it make sense to you? That is, it will allow us much better communication. It will allow us to be the ones who communicate it to the patient. If AI saves me time as a radiologist, instead of thinking that AI is taking my job and saying, let AI do it, what I need to do is say, I'm a radiologist, I'm the doctor trained for this, you come to my office and I'll tell you what I've seen in your image. Why is it a doctor who hasn't evaluated it who tells you about it? It's much better if I tell you, for you as a patient, for the quality of the system, but especially for you as a patient in terms of perception, you will understand it better. You will understand better what's happening to you, and you will be able to ask me your questions since I am the one who has gone through the thought process. When evaluating your tests, so the radiologist who doesn't use AI is the one who will be left behind. AI is an excellent tool.
But are there anti-AI radiologists?
Yes. There are all kinds, right? Just like everything in life, there are always people who don't see it. It's true that they're the minority, and above all, what there is for now are people who haven't had the time or the opportunity, because I've been very lucky in this. But there are people who haven't had the opportunity to get solid training in the use of AI in radiology, right? They will have it because they have the will. Gradually, more will come and the courses will become more accessible. Well, I've been very lucky. I've been at Harvard on this topic, and I've been very fortunate to be able to.
And there will be models that are specific for radiology, I understand, or very close to it.
There are specific models, yes, and those specific models keep getting better and better. And they will allow us to detect with much higher precision and get ahead of changes that the human eye is not able to perceive, right? And this, one of the tools I learned about there at Harvard is for the early diagnosis of dementia. Of course, dementias. What happens in Alzheimer's? Why doesn't Alzheimer's treatment work as well as we would like? The hypothesis is that by the time we detect it clinically, when the patient comes to the neurologist office because they notice something or others have noticed something, it's already too late. There's already neuronal damage we can't reverse. How can this be solved? By diagnosing it before any neuronal damage occurs. Well, you and I, you don't need to be a doctor for this. Can we understand that if I start speaking more slowly, or if I start moving my finger more slowly across the screen, or if I'm walking and keep stopping to write messages that are getting shorter and shorter? If my eyes move more slowly across the screen, anyone can understand that these could be early signs of dementia. But you and I, how do we realize that our grandfather is moving his finger more slowly across the screen? Not until it's already very obvious. But an AI application integrated into everyone's phone could see how fast or slow a finger moves, how fast or slow I type, and how fast or slow I speak.
Of course, especially the change over time, right?
Of course, and it starts to detect those patterns early on. Maybe that treatment we use for Alzheimer's or Parkinson's or whatever it's called starts to work better. Because what the human eye wasn't able to detect, it is able to interpret and provide a solution for, thanks to AI detecting it.
And I also sometimes think, for example, in dermatology, couldn't a smartphone diagnose with great accuracy using AI melanomas, basal cell carcinomas, squamous cell carcinomas, I don't know, any kind of dermatological lesion? If the cameras we have today in these devices are really good enough for that, right? I don't know.
From my perspective, extrapolating from that, considering that my specialty and dermatology are opposites, because they see everything that's visible to the naked eye and I see everything that's not visible to the naked eye. But taking that into account, when I see how it interprets a liver nodule or a lung nodule or a brain lesion or a breast nodule, seeing how it works and the patterns it follows and how it analyzes, you can perfectly extrapolate that to a dermatological lesion. I mean, the difference between the dermatologist and me is that I see the body from the inside and the dermatologist sees it from the outside. But in the end, AI can be
compare with previous images, previous patterns, and give you a diagnosis, right?
Exactly. In fact, I think any dermatologist would make a good radiologist, and any radiologist would end up being a good dermatologist because we apply very similar patterns and AI already does that. So, absolutely.
Well, there's going to be a boom in increasingly accurate diagnoses, and hopefully all of this will lead to better public health, right? That's what it's all about, isn't it? Yes.
And above all, I see that it's advancing very quickly.
That's great. Yes. That's great. That's great.
So we have to be prepared above all to take the reins of this and say, whatever helps us is welcome. And instead of being somewhat wary of it, which is also caused by ego, right? Say, hey, if this is coming, let's not be mediocre and just say no because it's taking my job. No. Let's see it as an opportunity and move forward. This has already happened. Of course, the Industrial Revolution, right? Luddism, Robert Owen, let's destroy the machines. It's not about destroying the machines. It's about taking advantage of the machines to create new business.
Yes, without a doubt, you always have to adapt to what's coming. It's like when Amazon came up, there were the anti-Amazon people. When Uber came up, there were the anti-Uber people. Glovo, when Glovo came up, it was the same thing. Look, yes, there are things that have negative consequences, but in general, you have to learn to live with them. There are things that inevitably arrive and never leave. I mean, they changed the world so much that it's impossible to go back. When a new president is set, it's very hard for Amazon to stop existing or for there not to be an alternative to Amazon. Exactly. If Amazon disappeared for any reason, another Amazon would appear. Yes.
There would be, well, in the end, that sharpens ingenuity. And by sharpening ingenuity, it makes society progress and humanity progress. That's another thing, right? machines are going to replace us. That's where the part comes in, where machines are giving us so much comfort that they're shutting down our ingenuity. Yes, yes.
That's the problem, yes.
Yes, that's where I see that, of course, you and I, well, we're people, probably everyone who's listening to us, curious people, active people, ambitious people, right? We want and use comforts well as an opportunity to gain other advantages. Could it make a lot of people rest on their laurels? Maybe.
Yes, in fact, there was already a study from Oxford and another from MIT that talked about brain rot associated with continuous use of AI, because in the end, if you delegate everything to it, you basically stop thinking, you stop making decisions, right? Yes.
Yes, it's a shame to do it that way. I use it in my daily life, but I think that nowadays it's absurd to say I use AI in my daily life because everyone does, right? So I also try to, ask myself things, ask it things. And many times those conversations even turn out to be enriching for me. Instead of saying, it already told me, right? And just leaving it at that. I think that depends more on how each person is, right? In each person's personality and what we need to start changing, I also see an opportunity, and this is completely my personal opinion. I'm not going to talk about the educational system. I see an opportunity to change how we educate and to finally get rid of memorization and retaining information just to spit it out. Absolutely.
Now, it really doesn't make any sense at all.
None at all. That needs to be overthrown just like absolute rest. Yes. So look, I see an opportunity, but it's an opportunity that requires effort.
Yes, but for me, there's a big difference between people who know how to use it well and those who don't. And the content creation ecosystem really affects my perspective, because you can spot it a mile away when a script is made with AI. I mean, I was watching a video and it was a girl who was also a healthcare worker, and she was talking to the camera and everything seemed very natural. But by the third sentence, you could tell it was a script read from an AI prompter. Because in the end, AI has a very AI-like way of communicating, and if we don't process that with our own human touch, everything ends up feeling very bland. Yeah, what's happening to me is that now I see the content and it's all the same, with the same sentence structures. All idiosyncrasy has been lost. Every genuine element in communication is gone. And that makes me, it makes me sad, but it's also another opportunity for those who don't do it or do it well. They're going to stand out. Because yes, exactly.
Right? It's about sharpening your wit and connecting with others. For instance, AI doesn't use subordinate clauses, does it? Look, we're going back to syntax. It hardly uses subordinate clauses at all. When you see it, I can also spot it very easily, right? Above all, well, I think we analyze the contrasts.
This isn't magic, it's science. This isn't physiology. If that's AI, I'm sorry.
Totally. Like I said, it doesn't use subordinate clauses or compound sentences, right? I mean, every sentence is self-contained. All the sentences are short. Everything is in some way very robotic. And what that's doing is making us lose that genuinely human communication, like you said. And it's really obvious, but it's going to make those who know how to stand out from that shine, or those who know how to use AI to get the most out of an idea, but not just tell it, give me a script, and leave it at that. I think it's going to make the people who use it sound more natural. There will be people who like it and people who don't. There are also people who might like the kind of communication that AI offers, right? There are all kinds of people in this world. Entonces, so I think, yes, it's going to make us different communicators, but we also have that advantage, especially when it comes to teaching kids how to use it. I think that's where the opportunity lies as well.
They're going to learn in 2 seconds compared to us.
Of course, but teaching them to use it properly so that there isn't that brain rot, right? That ego decay, and that's it. Rather, there's a strong opportunity in the education system now to get rid of memorization, prioritize, and start grading differently. How does a child solve problems? How does a child manage their emotions? How is a child, able to fix a table? I don't know, things we can start to focus on, of course.
There are really no limits with AI. None. The other day I was talking to a colleague who said, I programmed the application for my clinics for 6 months with AI. Yes. And he's a neurosurgeon. I mean, he's not a programmer. Yes.
The thing is, nowadays we can be whatever we want because you're an expert in whatever you want.
Act like an expert in astrophysics and yes.
Exactly. Help me build a rocket that reaches the moon, right? Well, probably if you have the means and the money, you can do it.
The same, yes.
I think it's quite likely that he would be able to.
That's great. Yes, yes. Well then, Jose, this has been a fascinating conversation. I think we could spend hours talking, right? Now let's eat a little here, get some sun, and enjoy Malaga a bit, right? And I don't know if you want to share a message with the audience to close the episode.
Well, yes, since we've been talking about a more human side of medicine, which maybe isn't so often associated with a radiologist, I would like to say that if I had to choose just one habit, one way to live our daily lives, if I had to pick just one thing I want my patients or the people listening to us to do, it's not eating, it's not exercising, it's not sleeping, it's enjoying what's in front of them. It's about being aware that if we can be doing this right now, it's because we don't have a bigger problem that's taking up all our energy and completely taking away our focus. So, when we feel bad, or it's completely normal to feel bad one day, to feel a bit down, but let's remember how lucky we are that there's not a bigger problem that's completely draining our energy. Every day we spend in this world without that loss of focus, that loss of attention, and even when that does happen, let's be able to enjoy what we have in front of us.
Be grateful, and all the viewers, thank you for spending this time with us. Very good.
Thank you very much. I'm grateful as well to you for inviting me and to all the viewers.
You already know that you have the biography of a healthy life, which is now available. You can find it on Amazon, where, well, all the advice he usually gives on social media, multiplied by 100, is in here. Very enjoyable, easy to read, and entertaining. Thank you.
I wrote it with a lot of care, really trying to connect, not to tell you what to do, but to invite you to live a little more happily, right? Well, that's it. Dr. Felices, what did you expect?
Absolutely, Dr. Felices.
Some people tell me that I'm too optimistic.
This is your home, Dr. Felices. We can do this again anytime. Thank you.
Borja.
One more episode, very practical from my point of view. Really, really good. Very practical, applicable. You've learned a lot from this episode. See you next time. Thanks for your attention and keep empowering yourselves.